Alrighty, so we're going to be talking about critical care first, but also hemodynamic monitoring, which once you cover all that in class, it seems really overwhelming, but hopefully we'll be able to break it down so that it's a lot more simple. So just to make sure there's just a study checkpoint here, just make sure you're still practicing your EKGs using the EKG simulator on SimStat, I think. Do ABG problems. Those will show up on tests, but more so on your final OSCE exam. Heparin calculations, now that you went over the heparin protocol. If you come to lab, we can go over those together this week. And then respiratory and cardiac medications, because there's just so many of them. So ICU, some of the most important things to remember is that the patients in here have limited communication. So a HESI tip or test tip, or actually just a real life tip, is to use whiteboards, yes or no questions, like still talk to them even if they're like in a coma, unconscious, sedated, and use comforting therapeutic touch when appropriate. For the family before they come in, prepare them with what they're going to see on the monitors, with all the wires coming out so that they're not shocked. So that's before they enter the room. As far as nutrition goes, most likely if they're in the ICU, they're sedated, they're receiving some kind of artificial nutrition. So whether it's enteral, meaning inside of the GI tract, or parenteral, which is through like a CVAD. Enteral is much preferred to parenteral because it keeps the gut active, but if it's needed, like parenteral can be used if gut rest is needed. Delirium, remember to know the difference between delirium and dementia. So delirium is a temporary condition caused by a circumstance. And so it's because of like constant noises and monitors, lights, visitors, like nurses coming in and out, don't get good sleep. And so one of the ways to combat that is to cluster cares to increase rest periods, provide earplugs, eye masks. So cluster cares would be like they have a medication due at 9 o'clock, they have wound care at 9:30, and another medication due at 10. So you go in at 9:30 to do all of those together. Okay, so you don't silence the alarms. So you can like silence them while you're like suctioning so they don't go off and cause more stimulation, but you want to make sure that you don't silence them like permanently because that's a huge safety risk, and it's just super, super contraindicated. So we do our best to decrease the amount of stimulation they're receiving, but alarms are one of those things. Like you can set parameters so that they only alarm when like certain things go off. So instead of like an oxygen saturation of anything below 95 alarming, you can do anything below 90, just as long as it's safe and within doctor's orders. So just like with catheters, when you have a catheter in, the best way to prevent infection is to always be assessing for when you can get the catheter out. And so when somebody's in the ICU, the best way to prevent delirium and long-term effects is to get them out of the ICU as soon as they're able to be released. Okay. There's more pain for ICU patients, meaning analgesia and sedation, like fentanyl and propofol. It's a common combination. A lot of times, like I felt weird at first, like using sedation as like the answer choice to a question because it seems like the most invasive, most extreme. But they're in the ICU and they have all these problems going on and they have tubes and all this stuff. Sedation is like the most caring thing you can do for these patients to keep them out of pain. And it also decreases the metabolic needs of their body, and so it gives them a chance to heal. Okay, talk more about that later. Okay, so hemodynamic monitoring definitions. This hemodynamic monitoring, like they explained in class, is basically just all the ways like we've been taught so far to monitor somebody's like cardiac function as well as the perfusion to their body. And then the hemodynamic monitoring parameters that we're adding in here, like central venous pressure, pulmonary artery pressure, are all things that they're just measuring volume in the body. And so right here it says monitoring the pressure, flow, oxygenation in the cardiac system can be non-invasive. So remember your 6 Ps, like your pain, perfusion, like your like pain, pallor, poikilothermia, or like cold, pulselessness, those ones, because those are really important. And if you in a question it says like there's a problem, like they have a cast on their right arm, what assessment should you be doing? And it's like, okay, well, I'm going to check the cap refill and if they can move their fingers, because those are your 6P assessments, and those are really, really important and will come up a lot. Vitals, urine output, loss of consciousness or level of consciousness. So those are non-invasive ways to measure hemodynamics, but more invasive is the catheter threaded into the heart. And those give the exact measurements, is where you get your CVP and all the stuff we're about to go over. So first thing, we want tissue perfusion. So tissue perfusion is the goal, organ perfusion, like all of that. And so that is the main goal of hemodynamic monitoring, is to see, are my tissues being perfused? Okay, so includes cardiac output, intravascular volume, myocardial contraction, and vasoactivity. So whether the vessels are constricting or dilating. So central venous pressure, CVP, is 2 to 8 mmHgs. Okay, this simply just measures the volume in the right atrium. It is the blood that has returned to the heart and has caused the atrium to stretch to a certain degree. And so the lower your CVP is, the less volume is in your body. And the higher it is, it can indicate like fluid volume overload or things like that. Pulmonary artery pressure is about 4 to 12. And this is just measuring like coming up. And I'll show you a diagram that will make more sense, but just remember these numbers. Pulmonary artery wedge pressure is the volume in the left atrium. So CVP and PAWP are the important ones. And to measure PAWP, you have to inflate a balloon on the catheter and it floats up through the pulmonary artery into the left atrium. Only done for a couple seconds to not occlude anything, but again, I'll show you a picture to make more sense of that. Cardiac output, just remember the formula to make it make sense. Stroke volume times heart rate is the amount out per minute. It's usually 5 to 7. Okay. And stroke volume is the amount ejected with each heartbeat, affected by preload, afterload, and contractibility. So preload is pretty much everything that's coming into the body through the superior and inferior vena cavas, and then afterload is the pressure that it has to overcome to push through, like the aorta, to get throughout the body. Contractibility is just how strong the heart is contracting. Okay. Cardiac index is taking cardiac output and it's accounting for the body's surface area to make it more unique to that individual. And then MAP is probably one of the most important things to remember. So this formula, and it should be between 70 to 105. Anything higher than that, you might have a fluid volume overload. Anything lower than that, your cardiac output is low. It's not getting enough tissue perfusion. 65 to 70 is about what is needed to perfuse your heart and your brain. But obviously we need more than that because we have our muscles, our kidneys, you know. Okay, systemic vascular resistance. So resistance, this adds to our afterload, okay? So it's going from the left ventricle out to the body. This is systemic, out to the body. Pulmonary vascular resistance is the right ventricle to the lungs. And then ejection fraction, we don't measure this, doctors do, or an ultrasound tech or whoever. They do an echocardiogram, so cardiologists will do that. And so 50 to 70% is normal, 40 to 49 borderline, less than 40 is dangerous, and less than 30 they'll go into possibly spontaneous VTAC to be fit. So I guess just remember, like, we're not measuring ejection fraction, but it is an important aspect of cardiac health. Okay. A couple more. SP, I always get confused between these, so it's just at this point making sure we understand. SpO2 is pulse oximeter, so that P stands for pulse oximeter. SaO2 is arterial blood pressure, and then PaO2 is the partial pressure of oxygen. So this is what you get when you take your ABGs, and this is 80 to 100. Okay, and then SpO2, it should be above like 95-ish. Okay. All right, so these are some reasons why CVP would increase or decrease. So CVP increased could happen because of overhydration. So whenever you think increase, just think there's way too much volume in the body. So overhydration, right-sided heart failure, which, remember, right-sided heart failure causes backup into the systemic system. So that would explain why there's like edema and extra fluid in the body. Cardiac tamponade, so it's increasing that pressure because it's a fluid-filled sac that's creating pressure on the heart. Constrictive pericarditis, same concept. It's constricting because of the inflammation in the heart and the pericardial tissue. Pulmonary hypertension, tricuspid stenosis and regurgitation. Stenosis is that hardening, and regurgitation is allowing fluid to back up. And then stroke volume is high. And so stroke volume, when we talked about it earlier, was all the like the preload, afterload, and contractibility. Then decrease CVP because they are hypovolemic. They've just lost a lot of fluids. They're bleeding, decrease venous return. They backed up in their legs. They're older, or in combination with other issues. Excess veno or vasodilation. Shock, that's a big one. And then if the measure is less than 5, wait, that doesn't make sense. I don't know. Ignore that. And so for PAWP, it's essentially the same thing as well. PAWP is the left atrium, CVP is the right atrium. Okay, so for increased pulmonary vascular resistance, we could have a pulmonary embolism that's blocking the pathway. Just any illness like respiratory illnesses, lung disease, hypertension, vasoconstriction, PEEP, acidosis increases your PVR. Things that decrease your pulmonary vascular resistance are vasodilation, hypotension, which like go hand in hand if you're giving oxygen, and then smooth muscle relaxers. So you're like alpha agonist. To increase stroke volume resistance, it can be hypertension, coronary artery disease, hypervolemia, clots, coarctation of the aorta, hypothermia, viscous blood, so it's thick, stress, cardio shock, they're obese, smoking, they're in pain, or they're anxious. To decrease SVR, morphine. So that's one of the big reasons that morphine and nitrates are actually given during a heart attack, because they decrease that systemic vascular resistance. They open the vessels to create the ability to have more blood flow to the heart. And then CCB, so calcium channel blockers, and then like things of shock. So it's just important, like you don't need to like go through this and memorize, but all of these have something in common, right? And so to increase, something's tense, something's tight, something's blocking, okay? To decrease, something's open, some medication is opening, other things are they're in a state of shock, okay? Okay, this is the picture I was talking about. It looks really confusing, but this will help clear things up a little bit, okay? So this is our pressure gauge right here. So we're 0 to 30, and we can see, so this is the catheter that they're going to be feeding through the heart to measure CVP, PAP, PAWP, and all of those invasive cardiac monitoring, the hemodynamic monitors. So CVP is the right atrium. So when the catheter is sitting right here, we can measure CVP, and we see that the levels are between like 2 to 8, okay? And then we go down into the right ventricle, and obviously we have higher pressures in the right ventricle because this is where the majority of the huge pumping is happening to send the blood up. So we have like a fraction. So we're going to be like 25 over just about like 4 or 5, 2 to 5 right here, okay? And then we feed it up to the pulmonary artery pressure. And this PAP is the venous blood pressure. So whenever we take blood pressure, we're measuring arterial blood pressure. But if you want the venous blood pressure, this is this right here. This is also a fraction, about 25 over 10-ish. So from the very top to the very bottom of that curve. Okay, and oftentimes since PAWP is pretty invasive because you have to, like I said, you float, like you inflate like through a port in the catheter, you push a little bit of air and it inflates this balloon and it floats up into to measure the left pressure right here, and it can block something temporarily. And so a lot of times they just take the bottom number of PAP, and that is your PAWP. If you take a real PAWP, the values you can see hover around 10 here. Okay. So this also looks pretty confusing, but hopefully we'll be able to clear it up. So the parts of a hemodynamic monitor. We have this pressure bag right here. It prevents blood from backflowing. There's a constant like drip of about 3 to 6 mils per hour, okay? And so we can see a pressure gauge here, and this like it's sort of like a blood pressure pump. So then we have, yeah, the manometer right here. So then we have two lines coming from, and these are our drip chambers with our, I can't think of the word, but you guys know what I'm talking about. And then our clamps, sorry. And then we come down, these are our flush devices right here. And then right here is the transducer, which is probably the most important part. This needs to be level with the phlebistostatic axis. And to understand what the phlebistostatic axis is, we can come over to the patient. And right here, the phlebistostatic axis will be the fourth intercostal space, so counting down, mid-axillary, so where your armpit is, midline, and it lines up with the right atrium. Okay. And so if your line is like, if you're not lined up and it's too high, you'll get a false low. And if it's positioned too low, you'll get a false high for your readings. Okay. And so this transducer needs to be in line with that phlebistostatic axis right here. And a lot of times people just, the phlebistostatic axis will be marked with like a Sharpie. And so that, and then to like get it exactly level, you can use like a carpenter's level with the bubble in the middle and the fluid, and to get it exactly perfectly in line. And I believe you can go up to, it's either 30 to 45 degrees without changing your phlebistostatic axis and transducer. You can turn to the side, you can flip like prone, supine, whatever. I think the only thing like you wouldn't want to like go into like Trendelenburg or like, I don't know, we'll go over that in just a second. But so this is the catheter right here that leading. This is like the main line that's going into the patient. This is where like you would be accessing all of the ports and stuff. And so right here, CVP port. So this is where you would be getting the CVP reading, which goes over here to this, and then we're going to be getting all the pressure readings coming onto this monitor right here, so you can read what the pressure is. You can see that there's a stopcock here, so if you turn it towards the line, you would stop any fluid from coming into that port, and if you turn it towards the port, you are allowing fluid to come. Like right now it's in the neutral position, and so if you turned it towards the port, you can get like, sorry, I think I'm saying that wrong. So if you turn it towards the line, you'll be able to pull out a blood sample, I think. Wait, now I'm confusing myself. Sorry. Yeah, I guess it is a little confusing. But as far as accessing the ports, you're going to want to try and, again, cluster cares to make sure that you minimize touching the line to decrease the chance of infection. So you do it the least amount of times as possible. If you need to draw labs, you just gather them all at a central time. Okay, so it says to turn towards the machine to sample from the patient, turn towards the patient to draw saline from the line. Okay, so this stopcock right here, if you position this and turn it towards the patient, towards the port, you'll be able to draw saline out of this line, because turning it towards something stops wherever this arrow is pointing towards. And if you turn it towards the line, towards the machine up here, you're able to draw a sample from the patient right here. Okay. And then if it's in the middle, that just means this fluid coming in from the bag is just flowing in. It's in a neutral position. Okay. And then right here, balloon port, that's what I was talking about to get PAWP. You have to blow up this balloon briefly. And so it's just like a set amount of air to blow up the balloon, float the catheter into the left atrium measuring spot, and then take it out once you get your reading on the monitor. Okay. And then the pulmonary artery port is right here. Okay. And so depending on where you need your sample from, you would be drawing from either one of those. And then before this line is placed, they're going to have an Allen test, which means you occlude the ulnar and radial arteries, and then you let go of one. Like you hold the radial and then let go of the ulnar and see if the hand flushes red, to make sure you're still getting blood flow to the heart once the catheter is in the artery. Okay. So go over this picture, make it make sense in your head. Just remember the big parts of this is that we have a pressure bag flowing constantly 3 to 6 mils per hour to prevent backflow. We have a transducer that needs to be in line with the phlebistostatic axis, which is marked on the body at the fourth intercostal space, mid-axillary line. And then you have your ports at your patient, where you can use the stopcock to either draw saline from the line or blood from the port. And then there's the CVP and the PA port with the PAWP balloon port up here. Okay, cardiac assist devices. So if there's cardiac damage or something happens, sometimes the heart needs a little bit of help to pump. So it decreases cardiac work and improves perfusion in the body. So you have an aortic balloon pump, and this just opens the vessel to reduce afterload. And so as diastole happens, so as everything relaxes, the balloon inflates to keep things open and promote flow. Okay. Ventricular assist device, it looks like this. It sits at the left ventricle, and then it just assists the ventricle in pumping, think through an electrical current. Okay. Of course, you want to be careful, like if your patients have these or like a pacemaker or anything like that, you want to make sure you know before they go to the MRI and get that, just so that because there's metal and MRIs use magnetic forces. Okay, so we'll just jump into questions. So go ahead and read that, pause, and we'll go to the answer. Okay, so the ICU nurse educator will determine that teaching is effective when, and the answer is B, positions a zero reference stopcock line level with the phlebistostatic axis. So zero reference stopcock line, transducer, same thing, essentially, and you want it in line with the phlebistostatic axis. Okay. So ensures that the patient is supine with the head of the bed flat for all readings, not necessary. Remember I said they can go up to like 30, 45 degrees, side to side, just as it's pretty flexible with that. You just have to make sure you know what positions they can't go into. Balance and calibrate some monitoring equipment every 2 hours. Well, if they haven't gone anywhere or haven't like drastically moved positions or something hasn't happened, you don't need to balance and calibrate the monitoring equipment. You need to make sure that it's like zero referenced and in line the phlebistostatic axis. But rechecks the location of the phlebistostatic axis when changing the patient's position. Well, like I just said, usually when changing position, the axis will stay the same. So, okay. All right, so appropriate nursing interventions for patient with delirium in the ICU. So A, using clocks and calendars to maintain orientation. This is just something to make sure, like, it's like a grounding technique. A lot of people like in long-term care facilities, they have really big clocks with the time really large and then the date really large underneath it, and the year and stuff like that. And that just helps them maintain like orientation, like what is today, what's going on. B, encourage round-the-clock presence of caregivers at the bedside. So round the clock, that would increase stimulation. We don't want to do that. We want to cluster cares to allow for rest time. C is sedate the patient with appropriate drugs to protect the patient from harmful behaviors. Again, you might be tempted not to click it because it seems really invasive, but for the ICU, it is appropriate. D, silence all alarms, reduce overhead paging, and avoid conversations around the patient. It's dangerous to silent alarms. Paging is essential, and conversation can be beneficial to the patient as long as it's clustered to allow for rest times in between. And then identify physiological factors that may be contributing to the patient's confusion and irritability. Why not? Great. Okay. And just remember that delirium, again, is that reversible, temporary situation caused by something happening in the environment, whereas dementia is irreversible, progressive, and caused by a disease or just physiological things happening in the body. Okay. All right, so they're caring for someone with a left subclavian central venous catheter and a left radial arterial line. Which assessment finding requires immediate action? Okay, so this is going to have to do with our 6 Ps probably before even looking at the answers. It says, so the answer is B, numbness and tingling in the left hand. So that's a sign that there is not good perfusion to the left hand and that left radial arterial line probably needs to be taken out. Okay. Slight redness at subclavian insertion site. Slight means like there's probably not a problem. It's obviously there's a catheter inserted there, so it's going to be a little red. Slight bloody drainage as well. Obviously, if it was like profusely draining red blood, or if it was super red, super itchy, that would be an issue. Okay. All right, so pause. Okay, you read in order to discontinue the left radial arterial line. When discontinuing the patient's invasive line, what's the priority nursing action? So B is apply pressure to the insertion site for 5 minutes. If you think about an artery, it's constantly getting blood pumped through it, right? And so blood, if it is allowed to come out of an artery where there's like a hole, it's going to spurt. And so to make sure that we get adequate clotting before we put the dressing and pressure dressing on, you want to hold pressure for 5 minutes at least. And obviously, if they have like ground blood thinners or anything like that, you're going to want to hold it for longer, probably about 10 minutes. Okay. Not that any of these other ones are wrong. It's just the priority nursing action is this. Right. Okay, so this is another common type of question. They get an x-ray. So just like with NG tubes or anything like that, after the doctor positions the catheter, an x-ray will be taken to ensure proper placement. The radiologist reports to the nurse the tip of the catheter is located in the superior vena cava. What is the best interpretation of these results by the nurse? So this means that the distal tip of the catheter is in the appropriate position. The tip of it should be in the superior vena cava. Okay. All right. Okay, so this is what I was talking about. They inflate the balloon of a pulmonary artery catheter with 1 milliliters of air to obtain the PaOP or PaWP. The nurse encounters resistance. What is the best nursing action? Okay, so whenever you see resistance in your head, you should be like, okay, I need to stop. And so C is the correct answer. Deflate the balloon and obtain a chest x-ray study to determine line placement. We don't ever want to, for example, A, add an additional 0.5 milliliters to the balloon and repeat the procedure. It's going to make it worse. Advance the catheter with the balloon deflated and repeat the procedure. No, we don't want to advance. And then D, lock the balloon in inflated position and flush the distal port with normal saline. No, we just want to pull it out. Same thing if you're flushing like a central line. A lot of like nurses use like the push and stop methods. Like instead of like when you flush, you have your 10 ml syringe, you aspirate a little, you get good blood return. Instead of just slamming that 10 ml syringe in, you like push a little, stop, push a little, stop. And then if you encounter resistance at any point, obviously you don't want to keep going because you can dislodge a clot and send it into their circulatory system. Bonus question, if they start having trouble breathing, you suspect that a clot was just dislodged from the central line, what position do you put them in? Okay, so the position that you put them in, you want to put them in Trendelenburg, so head down, and place them on their left side, and that's to avoid whether it's like an air embolism or something like that from going into pulmonary circulation and becoming PE. Okay. 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 So there was an insertion of a left subclavian central venous catheter, which assessment finding 2 hours later immediate action. So the answer is A, diminished breath sounds over the left lung field. So what can happen is when a central venous catheter is inserted, it can cause I can't always say this word, iagotrenic or something, pneumothorax. So it's a pneumothorax caused by a medical procedure. And so if you're listening to lung sounds as an assessment, if someone has a central venous catheter and you hear diminished lung sounds, you can suspect a pneumothorax. You're going to talk to the doctor, and most likely they're going to get their chest is going to be decompressed, and they're going to get a chest tube just to make sure to get all that air out if it is big enough. Okay. Measured CVP of 5 is normal. Slight bloody drainage around insertion site, we talked about this, it's normal. Localized pain, if it's localized and it's not spreading anywhere, we want to obviously treat the pain, but it's nothing to be crazy concerned about. Okay, so the charge nurse is supervising care for a group of patients with a variety of invasive hemodynamic devices. Which patient should they evaluate first? So the answer is C, a patient with a PaWP of 25 and an oxygen saturation of 89% on 3 liters of oxygen via nasal cannula. So remember that PAWP should be between 6 to 12. 25, anything above, remember, is there's an overload somewhere. So fluid overload can cause ARDS, and since O2 saturations are dropping, but they're on oxygen, this is a real concern, okay? Let's look at the other ones. A patient with a CVP of 6 and 40 milliliters of urine output in the past hour. So 6 is normal. 40 mils of urine output in the past hour, great, because there should be a minimum of 30 mils per hour that a normal adult outputs, or it's about like 0.5 mils per kilogram if you want to be more exact for the patient. And so since it's above 30, we know that the kidneys are being adequately perfused and they're able to make urine and excrete it. So not worried about them. They're functioning great. B, a patient with a left radial arterial line with a BP of 110/60 and a slightly dampened arterial waveform. Nothing to be worried about. All seems pretty normal. D, a patient with a pulmonary artery pressure of 25/10 and an oxygen saturation of 94% on 2 liters of oxygen. So 94 on 2 liters is really stable. 25/10, remember that's about, when we go back to that picture, the fraction, that's perfectly normal for PAP. And remember that this bottom number can be used as the PAWP if we're ordered not to inflate the balloon for PAWP. Okay, so the nurse is caring for a patient after a left subclavian central venous catheter has been inserted. Which action by the nurse best reduces the risk of catheter-related bloodstream infections? Okay, so again, best reduces, like the same thing with like a Foley catheter, or if they're in the ICU, the best thing to do is review the daily necessity of a central venous catheter. If they're not needing it anymore, the best thing to do would be to take it out and cuts that risk of infection. And then right here, maintain a pressure 300 on the flush bag. Remember, it was only 3 to 6, and so that's crazy. And then change the pressurized tubing system and flush bag daily. Not required. That's too much introducing of like infectious agents. Cleanse the insertion site daily with isopropyl alcohol. Well, I mean, you want to make sure it stays clean, but there's going to be a dressing on it. So, okay. Okay, nurse is caring for a patient with a pulmonary artery catheter. Assessment findings include a blood pressure of 85/40, heart rate of 125, respirations of 35, and an arterial oxygen saturation of 90% on 50% Venturi mask. Hemodynamic values include cardiac output of 1. So at this point, you want to remember what is the normal. First off, we know this blood pressure is not good. We're this far in the nursing program, we know that 85/40 is not looking great. Heart rate of 125, again, respiratories of 35, and SpO2 of 90 on 50% Venturi. None of their vitals are looking great. But now we're looking at our new thing. So cardiac output of 1, it should be between 5 to 7 for normally functioning adults. So this is very low. CVP of 1, this is also low. And a pulmonary artery PAWP, they call it inclusion pressure, but it's the same thing, is 3, which is low. The nurse questions which of the following physician's orders. So questions meaning which one is wrong. So 1, titrate supplemental oxygen to get SpO2 over 94. Not super necessary. I mean, they're doing okay at 90. I'm probably more worried about these other things, but this wouldn't be the worst thing in the world, right? We wouldn't question that order. B, infuse 500 mils of a normal saline bolus over 1 hour. This would be a good thing, right? Because their blood pressure is dropping, their heart rate's up, respirations are super high. We're wondering, like, are they going into shock or something like that? So great. Obtain arterial blood gas and serum electrolytes. Well, yeah, we would want to know what their ABGs are, right? If they're in an acidotic state, because, or if they're in alkalosis because they're breathing super fast, right? And then D, administer furosemide, 20 milligrams intravenously. So this question essentially makes sure you know what Lasix does to the body and know that if my pressures are low, that means I have a fluid volume deficit. And if I give them Lasix, then I'm just wasting all this fluid and electrolytes, making the problem even worse. Okay. So that's how like you can use all those pressures to determine like, okay, this would not be a good treatment and this would be a good treatment. Because all that we're measuring here is pressures in the body and perfusion to the body. Okay. Okay, so the nurse returns from cardiac cath lab with a patient following the insertion of a pulmonary artery catheter and transfers the patient from stretcher to bed. Prior to obtaining a cardiac output, which action is the most important for the nurse to complete? So the answer is zero, referencing the transducer system at the phlebostatic axis. So like I said, when you transfer somebody or like they go to get like radiography and come back, you want to make sure again to position that transducer at that zero level phlebostatic axis, fourth intercostal space, mid-axillary line, lining up with the right atrium. Okay. And the rest of it is not indicated at this point. And then these are great videos to understand what the heck all of this is talking about. And then that is it. I would use those pictures and like be able to walk yourself through, like, for example, these pictures right here. Let me go all the way back. Okay, so like you want to know like what increased CVP, decreased CVP, all these definitions right here, what they mean, what could increase PVR and SVR, and then understand what's going on here. You definitely want to know values for CVP, PAP, and PAWP. You want to know what's going on here. Most importantly, like how much is coming into the bag. Um, Transducer needs to be at phlebostatic axis, what the phlebostatic axis is, pressure monitor, and then clustering labs to minimize touching the line, what the stopcock does when you turn it towards the patient or towards the line, the balloon port, what that axis is, and like if you were to insert, if the doctor was to insert like a radial arterial line, making sure to do the Allen test to make sure that the hand gets perfused by the ulnar artery. Oh, I guess I did write it over here. Patient can sit up to 45 degrees, turn side to side, and lie prone without changing the axis. So there's your definitive answer. Okay. Sorry if that was a little confusing. It's not as long as the other videos, but it is definitely important to know. It's going to be on a lot of your exams and in combination with things like the respiratory system, like ARDS, and like we're going to be talking about shock. And so you're going to be using these hemodynamic monitors to assist you in understanding other lessons as well. And that is it. So awesome.